Hello and welcome to the Family Heart Foundation Familial Hypercholesterolemia Community Forum. We're really thrilled to have you all here. My name is Kat Davis Ahmed and I'm Vice President for Policy and Outreach at the Family Heart Foundation. And today we are just thrilled to have Dr. Christie Ballantyne moderating a panel discussion with three of our advocates for awareness to talk about their experiences living with familial hypercholesterolemia and homozygous FH, Aditi Durga, Sydney Phillips, and Brandon Wilson. A few housekeeping items that we have. This presentation is not intended as medical advice, so please consult with your doctor or your medical team for any specific advice related to your health and your treatment. Please introduce yourselves in the chat and make sure to choose everyone so that everybody can see your comments, say hello, who you are, where you're from. And throughout the conversation, we'd love it if you would share your own experiences on the theme of the underdiagnosis and undertreatment of familial hypercholesterolemia. It's just really great to have you all here, and it's great for everybody to meet each other virtually. If you have a question, you can put it in the Q&A at any point in the presentation. We'll open it up to Q&A later in the program at the end of the panel discussion. So please put your questions in the Q&A and we will get to those at the end. I would really like to thank the generous support of we're grateful for the generous support of our corporate sponsors, Amgen, Aspirion, Konica, and Bio, for the FH Community and Action Program, and for the homozygous FH Community Program, Regeneron and AMRIT, and for Invitae's support, providing free genetic testing to those who may have homozygous FH through a program with the FH Foundation. And we're especially grateful to the families and the individuals who support our programs. First, I would like to introduce Dr. Christie Ballantyne. Hello, Dr. Ballantyne. Thanks so much for being here.
Hi, Kat.
Dr. Ballantyne is the Chief of Cardiology and Chief of Cardiovascular Research at Baylor College of Medicine, and he's currently the Director for Cardiometabolic Disease Prevention at Baylor College of Medicine. He's an internationally renowned expert on lipids, atherosclerosis, and heart disease prevention. And he was awarded the Baylor College of Medicine Michael E. DeBakey, MD, Excellence in Research Award, among many other accolades. His research in biomarkers has led to FDA approval of 2 biomarkers for risk prediction in cardiovascular disease. And he's played a prominent role in the development of FDA-approved new therapies for the treatment of lipids, including a lot of clinical trial research and other research. We're very proud that Dr. Ballantyne is a member of the Scientific Advisory Board for the FH Foundation and a member of our Cascade FH Registry Network, and has been very much involved with the Family Heart Foundation since the very beginning. So thanks so much for being here. We're going to have a little introduction to FH before you jump into your panel discussion.
Thank you, Kat. So it's just important that we all understand what we're talking about. And this is a nice schema, F plus H. So in terms of the diagnosis, the key is family history. Now that can be a problem if someone's adopted, and then we end up sometimes with more reliant upon genetics, but family history, high LDL cholesterol, and the numbers that we keep in mind are over 190 for adults and over 160 in children. And if you have a family history and a very high LDL cholesterol, then you should be suspicious that you have familial hypercholesterolemia. Next slide. All right, so we think of this as a kind of a classical genetic disorder that we would call, used to call autosomal dominant. But basically, if you have one bad copy of the gene, this will raise your LDL about twice normal. You end up having a risk for having a heart attack at a young age. It's common. It's about every 1 in 250 people. Now, the more difficult situation is if you get one bad copy from each parent. Now you have 2 bad copies of the gene. Usually it's the one that encodes the LDL receptor. And now you have extremely elevated levels of LDL cholesterol, and you can begin to have heart attacks in childhood. And it's much more difficult to treat. Fortunately, now we have therapies for all of these conditions. It's been the improvement in available drugs is fantastic since I first started seeing patients in clinic quite a while ago. Let's go to the next slide. So as mentioned, this is a common disorder. It's about 1 in 250 individuals. And if we look at this in kind of the broader terms, it's even more frequent than that, most likely. And the unfortunate thing is that although we have a tremendous number of very good medications, only about 20% are diagnosed. And then they frequently are diagnosed much later in life than they should have been. Let's go to the next slide. So, the guidelines for screening, you can diagnose this disorder if you measure blood lipids, and that can be actually diagnosed at birth. But if you were even in childhood at 2 years, if there's a family history, it's recommended that there be screening. Treatment ideally begins for heterozygous FH around ages 9 to 11. Now, look, when FH was, we have been part of a registry that's been organized by the FH Foundation called the Cascade FH Registry. Unfortunately, on average, statins were initiated at age 39. So you have lifelong exposure to very high levels of LDL cholesterol, and therapies begun much later than it should have been, which means that the arteries have been exposed to this high cholesterol and building up plaque. Unfortunately, sometimes they're diagnosed after the heart attack, not before the heart attack. And frequently they weren't told that they had familial hypercholesterolemia until age 47. That's far too late. Let's go to the next slide. So this is a disorder that is life-threatening. It causes heart attacks and strokes. 1 in 5 heart attacks under the age of 50 is caused by familial hypercholesterolemia. And, we talk about cardiovascular disease as being the most common cause of death in the United States. With early diagnosis and treatment, this is completely preventable. And that's the real, shame here is that some of our cancers and other things, we don't fully understand what causes them. We understand what causes FH and we know how to treat it, but we're missing the diagnosis until too late in life. Next slide. So it turns out that physicians in general, they start statin therapy when they do a risk calculator. If someone has an LDL that's over 190, if it's 200 or 220 or 230, you're not supposed to do the risk calculator. You're just supposed to treat. And you start with statins, but we have other agents that can be added to statins: ezetimibe, PCSK9 inhibitors, bempedoic acid, biosequestrants, lipoprotein pheresis. And we have therapies for homozygous FH, which used to be not responsive, that you can use lomidopide and evinacumab. So a lot more options. And if you use these options, you are frequently, in most cases, at least for heterozygous FH, able to get to targets. And even now for homozygous FH, you can have tremendous improvements in the levels. So it's very important that people understand, the physicians, and sometimes as a patient, you may have to advocate, if your physician is not aware of this, that in fact, if you have a hereditary disorder, you don't wait. And the other one is, particularly if it's your children, get them started early. Next slide. So it's very important to start early. The earlier, the better, but it's also important that you continue to advance the therapies until you get your LDLs down to a low level. And unfortunately, this, even in people with heart disease, we saw that this was not achieved very commonly in the Cascade FH registry. Let's go to the next slide. All right, so with that brief background, what I'd like to do now is to introduce our panelists, Aditi Durga, Sydney Phillips, and Brandon Wilson. And that what we'll end up doing is each person will share a little bit about their story and some of their journey. And then we'll have opportunities for discussion among the panel and also taking questions from the audience in regards to what they have gone through in some of the other issues. So we'll start off with Aditi, if you would like to share some of your experiences.
Hi. Hi, I'm Aditi Durga. I am originally from Trinidad and Tobago. I was born in the US, but I grew up in Trinidad and Tobago. And I've been diagnosed with FH officially as of last year. So I was 28 years old, and it happened after I had my first mini stroke, which is called a TIA. It happened right after my cardiologist basically lowered my previously prescribed medication. So I was on statin. He lowered it, said that, I needed to think about the fact that I'm a woman and that I need to think about having a family at some point, and lowered it. And then 6 months after, I had my stroke, and that triggered the correct care. So it's a blessing in disguise because I was able to get onto the FH Foundation. And now I'm here to share my story with you guys.
And Aditi, when did you first know that you had high cholesterol? When was that first diagnosed?
So I've always known that heart disease ran in my family, and I've always known that our family had high cholesterol. I officially had my first numbers checked after my dad died when I was 22, and my cholesterol levels were 409, and my LDL levels in particular were like 396.
Wow. Okay. So it was known, but you had this, in your case, very high numbers. And then they never made the diagnosis of FH until you actually had a clinical event. That is.
And it wasn't my clinical event. It was my dad. He passed away, and then I went to check my lipids. And when I checked my lipids,
okay.
Yep. I went to check it. I was like, well, what are my numbers? If his numbers were like 500 and something, what are mine? And he was in a coma. So, that's what triggered. And that was the first time I saw my numbers. And then after that, I really started to check my numbers almost every 3 months, but nothing was done from the age of 22 to the age of 28 to give everybody an idea.
Okay. So Sydney, and you can, if you want to unmute and then tell us more about your experiences.
Okay. Hi. My name is Sydney Phillips. I'm from Pittsburgh, Pennsylvania. And I just want to apologize in advance if you see a cat with a cone walking in front of my screen. That is my cat. She had surgery last Friday, and she does not like to leave me alone. But anyway, so I was diagnosed with homozygous FH when I was, I was diagnosed with homozygous FH when I was 18, but I was originally diagnosed with heterozygous FH when I was 14. I had xanthomas deposits on the back of my Achilles tendons for as long as I can remember. And I used to do karate, and my karate master actually pointed it out, and he said, that's not normal. You need to get it checked out. So we originally thought it was an orthopedic problem. So I saw a physical therapist for 8 months, and the pain was not getting any better. It was making my shoe size, half a shoe size, bigger on my right foot than my left foot.
So Sydney, explain to people when you say a tendinous xanthoma, what was it like? Was it thick? I mean, explain to them what it looked. Yeah.
It's like a cholesterol deposit on the back of my Achilles tendon. It's not like a bony kind of feeling. It feels more like a tendon or a muscle. What we ended up finding out when they wanted me to have surgery to get it removed is my Achilles tendon had microtorn, and the cholesterol was so high that it weaved itself in throughout my Achilles tendon. My surgeon told me that my Achilles tendon looked like a marbled piece of meat, which was very alarming to hear. When I got my lipid panel done right before surgery, my LDL cholesterol was 704, and my HDL was 3. So very alarming for someone who is 14, active, doesn't have that bad of a diet. I saw a pediatric lipidologist for 4 years. My medication changed about every 3 months, different dosages, different medications, whatnot. And my cholesterol never came below, I want to say 320. So in March of 2018, I got genetic testing with both my parents, and that's when we found out that I had the homozygous form of FH. So since then, I've started on PCSK9 inhibitors, the lipoprotein apheresis, originally every week, now every 3 weeks-ish. And my baseline cholesterol now ranges between 190 and 140. And I also got an AV fistula last July to help with the apheresis, which is basically a type of dialysis port.
Okay, thank you, Sydney. So this was an example of when there was a very extreme elevation of the LDL cholesterol, and then also, which is classical for homozygous FH. And you did respond some. You went from 700 to 390, but of course, that's nowhere near where we'd like to be. And that's also fairly common, is that even after people use a statin, ezetimibe, the numbers are very, very high. So that would be, if that happens to you, you should be thinking about that this is a very important problem with it. But you fortunately now you've got things with a much more aggressive treatment regimen. And that's one of the issues, that we fortunately do have these therapies, but sometimes it takes a while for people to work their way there. Brandon, welcome, and tell us your story, Brandon.
My name is Brandon Wilson. I am in Fort Walton Beach, Florida, the Sunshine State, and I love it. I love the beach. Well, I was diagnosed when I was 8 years old, shortly after my father passed away. He was 39. We started to learn family history from his side, and it turned out most of the men on his side didn't make it past 40. So I knew this my entire life, and then I struggled in my 20s with chest pain and getting people to really take anything seriously. Some people would throw a statin at me and say, okay, well, you need to eat better. Until I had my first heart attack at 29. My LAD was 99% blocked. And it turned out that I would have a second heart attack that year. That was in 2015. And after that, I really struggled with insurance and trying to find a doctor that would prescribe me, keep me on a program where I could pay in cash or anything I could really do. And it was really just, you need to eat better. And I mean, I would even go to the emergency room just to get, a statin, just because I needed it. And it wasn't until last year, August of last year, I had my third heart attack that led to quadruple bypass. I was 35 years old. I really started to try and find answers and take it as seriously as possible and find a doctor that would do the same for me, which is still a challenge to this day. 15 months after quadruple bypass, you'd think some people would say, oh man, he's got issues, he needs help. I was under a cardiologist care that would put me on a low intensity statin and a PCSK9 inhibitor and say, here, you should be healed magically. And it was helping my numbers, but my LDL was 404. And it really wasn't doing the trick. I mean, the PCSK9 would bring it down a little bit. And I guess he thought it was fine. I actually went to him and asked to put me on a higher intensity statin as well as Zetia. And he said, no, let's keep it at this for now. It seems to be doing the trick. And I even mentioned this is not in the guidelines of the American Heart Association. I'm supposed to be on stronger, higher intensity medicine. And I really had to advocate for myself. So I found myself a new primary care physician that said, you know what, you're special. You need to be on this medicine. And he has been a godsend. He's just given me everything that I need to bring my levels down. And now my LDL is 49 in just a year of treatment. It's amazing. I never thought I would see numbers that low. And now I have my daughter, I have 3 biological children, 5 altogether, and only one of them has my gene. She has FH. So we got her tested yesterday, and her LDL is not what I want it to be. It is 204, and she turns 2 in 2 weeks. So now my life goal is to make sure that she never has to go through the things I have. She never has to suffer through any of the cardiac events that any of us have to go through, because early detection will save her life.
Okay, so these are really some powerful stories about the importance of advocating for yourself. I mean, it's one of the things that unfortunately, although 1 in 250 is not rare, a lot of physicians don't have much experience in this area. And so, you know, Brandon, the other one that comes up is, unfortunately, it's a strange thing that physicians are very used to understanding that when you're treating blood pressure, you may have to use 2, 3, or 4 medicines, but there's still a great reluctance to do this for cholesterol. They're both chronic asymptomatic disorders. I mean, and it's been because there was a lot of confusion with the guidelines a number of years back when they were focusing just on statins. But your example is one where you, not uncommonly, they'll say, well, you know, you ended up having to use 3 together, and 3 together is much more likely to be successful with it. But it is something in terms of pushing this together for this. So you've each gone through some efforts here in regards to doing this. Now, one of the things that does come up, Brandon, is that for your daughter, it'll be important to get her pediatrician into the loop, right?
Her pediatrician, actually, I told her about it about 6 months ago, and I said the regulations, or the suggested time would be to test her at 2 years old. And she was all about it. She said, let's do it. So I'm so lucky we have a proactive,
very good
pediatrician, and she's being recommended to a pediatric cardiologist as well. So we're on top of it, and it's amazing to have somebody that's treating her better than I got treated. That's for sure.
So one of the things that's a really important message is that you get all your kids checked, which you've done, Brandon. And I guess that's the other one in terms of Aditi, your family members, you know, in Sydney, were there other family members that your experiences have led them to being, you know, finding out that they have problems? Or did both of your parents have high cholesterol, Sydney? Did they know they had FH or not?
No. My mom has been taking statins since I was born. Her cholesterol was in the 500s. She was never officially diagnosed with FH, but my dad, he never knew that he even had high cholesterol. Sorry, the cat is very distracting. He never even knew that he had high cholesterol until we got genetic testing, and we found out that I got the gene from both parents, and he got his cholesterol checked, and it was in the low 200s, and his primary care physician told him that was fine. And he was like, no, it's very much not fine. My daughter needs to have her LDL under 70. Like, why is it okay for me to have a LDL of 190 and it's not okay for her? And the reality is that it's not. My mom's side of the family, my grandmother is still living. She has her cholesterol under control, but my Nana is one of 7, and all of her siblings passed away before the age of 50, including her parents as well, all from heart attack or stroke or cardiovascular related diseases. Unknown on my dad's side of the family, though. This was a new discovery when I was diagnosed with AHOFH.
And Aditi, about in your family, have you had cousins or other people who were, sometimes that's one thing, is to get all the family awareness of this so that everybody gets tested and then, you know, understands that if it's elevated, they should be treated.
Yeah, so with regards to my family, we were always aware that heart disease ran. Like, I think it was just known from when I was a kid that people just died from heart attacks, and it was just so normalized because that was just what happened. My grandparents already passed away. the most I could remember is my grandmother passed away when I was maybe like 10. But like for the little time that I had her, I remember her just being very sick, and I thought it was strange because my grandpa would do everything for her, but it was because she was always in and out of the hospitals. And I always thought it was just cute that he'd always make sure to take her for a walk. And I thought that's just what old people did, but I didn't understand it was because that was just getting her exercise in because she suffered with this. And after that, my dad experienced his first heart attack. I remember I was very young. He was staying downstairs, and I was very confused when my dad wasn't staying upstairs with us. But they hid it from me because I was a kid, and they obviously didn't want his daughter, his one and only daughter, to see him not be able to walk. But he did experience it as early as 35. I have 3 older brothers. 2 of them experienced their first events. My biological brother, which we have the same mom, same dad, he had his first massive heart attack when he was 25, which was a year after my dad passed away from his massive heart attack at the age of 59. And my eldest brother, Junior, he had his first stroke when he was 28, then had another stroke when he was 32, and then had a heart attack and TIA when he was 34, which was very recently.
So these are you have very strong family histories. And so when we see this, it's very important to get what we would call a lipid panel. That's usually total cholesterol. It'll give you LDL cholesterol, HDL cholesterol. Sydney, you had an extremely low level of HDL cholesterol. I also would recommend that for our audience that you get something checked, lipoprotein little a. Because what ends up happening is sometimes you have a double whammies. If you have FH, you may, and a very high LPA, then you may have even more accelerated. So Brandon, you have a high LPA. Yeah, so that there was a question where someone was asking about, and the audience said, your LDL is 49, is that too low? It's actually, that's where we want it to be, because what ends up happening is that we've done the trials now with these large studies where people were using the PCSK9 inhibitors, and they got LDLs on average between 30 to 50 in both of those studies. And we saw no adverse. In fact, they had better outcomes with lower LDL levels of cholesterol. And we haven't seen any adverse on hormones or other factors with it. Sydney, the homozygous FH, that's a one that really, you mentioned you ended up you're seeing an expert now though, right? You got referred over.
Yes, I am. I first was seeing a pediatric lipidologist. He was the only one that specialized in pediatrics in my area. And the biggest thing that was really hard for me at that time is as a 14-year-old, I didn't really understand what FH was, how serious it was. But what I did understand was how my doctor treated me. I constantly felt like my doctor at the time treated me like a case study. He had very little bedside manner. He would say things to me that just kind of threw me the wrong way. And as a teenager, I would like to do things in spite. The biggest thing that comes to my mind was he asked me what my favorite food was. And I said Chick-fil-A. And he looks me dead in the eyes and he said, well, maybe you should stop eating Chick-fil-A. And then my mom took me to Chick-fil-A immediately after our doctor's appointment because I knew, because he was telling me that it was not a diet problem. The diet and exercise only accounted for like 10 to 15% of my high cholesterol, yet by the same token, he was telling me to stop eating Chick-fil-A. So I really didn't take it too seriously. And then the moment I turned 18, I was like, I'm done. I need a new doctor. So I started seeing another doctor closer to home who is an adult. And I still didn't feel like I was taken completely seriously with my HoFH diagnosis. He was very inaccessible. He would only want to do a very brief checkup with me once a year. And I was like, this feels wrong. I'm being told constantly that this is a serious disorder and I need to do everything that I can to keep it under control. And seeing my doctor once a year wasn't really cutting it for me. So now through the connections that I made through the FH Foundation, I am now seeing a doctor at the University of Pennsylvania. And I have never been happier with the care that I have received from my doctor at the University of Pennsylvania. I really feel like she takes me seriously, which is also another thing that I've struggled with, not just with my cardiologist, but elsewhere. Really quickly, I know I'm kind of rambling, but in April, I was walking home from dinner with a friend, and I started to feel like really weak on one side. And I looked in the mirror and I saw that one pupil was way more dilated than the other, was not reacting to light at all. And I'm a nursing student. So my mind immediately goes to, oh my God, I'm having a stroke. So I take my roommate takes me to the emergency room, and I explain my complicated cardiac history. I tell them, hey, I have blockage in my carotid arteries. Like I have HoFH. My cholesterol is really high. I think I'm having a stroke. And I waited in the waiting room for 2 hours. I had to beg for someone to see me and to get a CT scan. I'm like, I know my body. I know my disorder. Please just do this for me. They thought it was an eye problem. Like I got something in my eye, and that's why I wasn't reacting to light. So finally got a CT scan after 4.5, 5 hours of waiting in the emergency room, and they found that I had a blood clot in my eye. Mm-hmm. And I think finding providers that take you seriously, regardless of your age, how you look, whatever, is really important. And unfortunately, that's not something that I've had a lot of luck with, but now I feel like I'm in a little bit better of a position.
So you bring up a really good point, is that if you're young and thin, and even more so if you're a woman, people tend to think, well, she can't have heart disease with it. So it's a little bit kind of ignoring the not being familiar with or ignoring the genetics. So it's even more important that you advocate for yourself and be aware of all these things. Important for the audience to know this. And the other thing that does come up with homozygous FH. So we talked about, Brandon, how you had to be pushing, because in terms of, okay, well, but there's statin, but there's also ezetimibe, there's also PCSK9 inhibitor, and those should be all kind of used routinely now for heterozygous FH with it. We have some older drugs, bile acid binding resins and niacin, that can be considered with it. For homozygous FH, you also have other drugs, which a lot of doctors are not aware of with it. So lomidopide, there's a new one called evinacumab, and there's also apheresis, which most physicians are not very familiar with it. So it's very important, Sydney, you were at Penn and they have a lot of experience in this area, but you need to go seek out sometimes. And I know that I have on the website, you'll have information to help people get to meet some of the, physicians who are, more expert in this area with it, because there are advances being made all the time. There's a lot in the pipeline for Lp(a). That's another area but the PCSK9 inhibitors help some for that. Apheresis helps for Lp(a). So there are still, even though the ones that we have a lot more treatments than we used to for this, and each person's different. Each person may have different, responses to therapies, and it takes a lot of working through and follow-up visits, and it takes the persistence that y'all have had for it. I think, let's see, how are we doing on a time here, Kat? Do we want to go to the questions, or? Yeah.
I think I'm incredible, you guys. Thank you so much for sharing your stories. I think we do have some great questions, and I'm sure we'll bring out more in your experiences. One early question was at what point are you not supposed to use the risk calculator, Dr. Ballantyne? This is for you.
So, if you have an LDL over 190, no one needs to be using the risk calculator on you. And then the other one that comes up, we hit. So this is, I think, Sydney, you point out that some people may have LDLs that are, I think then it may be a little on the lower side. You can have the gene, maybe you have something, you may get a bad gene from one parent, but a good gene from another one. So your LDL might be 170, but you still have the gene and you can pass it on to your children with it. So you might miss it. You might have a cholesterol that's 200 something, not terribly impressive, but so it's still, and you know, though there, if you make the diagnosis by genetics, you should treat the person with it. I don't know. Now let's see, Sydney, you had genetics testing. Brandon, have you had genetic testing or not? And Aditi, did you ever get genetic testing or not?
So I got my endocrinologist after I had my TIA. My neurologist realized that I had a previous stroke and then passed me on to an endocrinologist for testing. And I don't think it was official genetic testing, but he did a test and realized that I had elevated levels of apolipoprotein B, and then gave me the official diagnosis and said, yeah, it's apparent, like with your numbers, and then knowing that you have elevated levels, that you do have FH. Correct. And we're going to put you on our ICD10 code now.
And you can make this, it's nice, you can make the diagnosis simply by the family history and the lipid levels. Mm-hmm. And that's very important, because it does turn out that if they use the ICD10 codes, this is what, if there's a patient, it'll help you get your medicines reimbursed. They actually have to put the words in there, familial hypercholesterolemia. If it's not in there, sometimes the medicines are denied. So there are certain things, I mean, it seems ridiculous, but our healthcare system, as you know, is crazy sometimes. And so if the physicians don't put the right words in the note and use even the right codes, it can make a difference as to whether the lab tests are covered and if the medications are covered. And, you know, Brandon, you mentioned all the problems you've had with getting your medications and your insurance for it. Now, if the genetic test doesn't show FH, but if your numbers are high, you can still have a clinical diagnosis of FH. And that's what we don't want to do, is ignore somebody who has an LDL of 250 and they don't have a genetic test that's positive. Mm-hmm. That person still needs to be treated with it. ApoB is another test that tells us about bad particles with it for it.
And so Dr. Ballantyne, actually, it leads right into one of the other questions. And I think, I don't know if you can summarize briefly, what is ApoB? Because it's not totally different, right? What does ApoB contain? What does that test mean? And also maybe you could comment on the role of particle size and type when the LDL is so high.
So what ends up happening is we talk about LDL, it basically, that means low density lipoprotein. So remember, cholesterol is a fat. It's insoluble in aqueous solution. So to get transported in your bloodstream, you have these little balls. They have cholesterol and triglyceride. And, you know, if you throw fat with water, what happens? It floats. So to keep it in solution, you have proteins that are wrapped around the little ball, and that protein is called ApoB100. It's a protein that allows that, it goes in and out of the cholesterol part and it keeps it in the solution. So for each LDL particle, there's one ApoB molecule. So ApoB100 is also, it can be used as a way of looking at the number of particles you have. Most of the cholesterol is LDL cholesterol, so we use that as an important one. But there's some other particles that are also bad, called IDL. There are other particles, so LDL particle concentration is also important. ApoB is also useful. There are other tests that people can get that sometimes, if someone's LDL maybe is, it may not be quite as high as the ones that we've heard here, but they still have lots of particles, and they should be treated. There's other tests that physicians will get sometimes to look at this.
So ApoB sort of represents LDL and other
bad particles.
Bad particles. And so when the LDL is very high, concentrating
ApoB will be high.
ApoB will be high, and concentrating on getting the LDL down is really where you're focused at.
That's correct. For most cases, if you get the LDL cholesterol down, that'll happen. That some people have triglyceride problems, and that's a little different. Those are different disorders with it. and that people with triglyceride problems, sometimes they have these much smaller LDL particles and they don't contain as much cholesterol. So other measurements might be useful there.
I think that's very helpful. And so I think two things that you said at the two extremes, right? One is that any LDL over 190, that's severe hypercholesterolemia with or without FH, it should be treated, and the risk calculator is not applicable.
You don't need to do it.
And is there an LDL level that is too low? Is there a point at which you worry?
So, if it's due to medications, we haven't seen this. Now, what I would tell somebody is that if someone out of the blue is not taking medications and their levels of cholesterol drop tremendously, or LDL drops for no apparent reason, we begin to worry about, well, geez, is there something wrong with them medically? I mean, because if someone has cancer or heart failure, your metabolism's all wrecked up and your cholesterol levels drop down. So cholesterol can be a measurement of health, but if your cholesterol levels drop because you're taking a medicine, that's very different than if somebody were sick and malnourished. Their cholesterol levels may drop tremendously, but that's a totally different mechanism than what the medications are doing. So when we're taking the medications, we have not seen that the low levels of LDL are causing a problem.
Thank you. And I think we're honored to have one of our attendees is Miss Patricia Young, who will put a call out to see if there's anybody older with homozygous FH, but this is good news for those with homozygous FH. She has confessed in our chat that she's 67 years old and she's seen at Johns Hopkins, and they're thinking she might be one of the oldest with homozygous FH. So that's great news. And I think you're right with all the great medications that are available. We hope that that's the story for everybody. And there aren't any other questions that I'm seeing that you haven't already addressed, and I want to make sure you have time for your final thoughts before we wrap up. Any thoughts that you all have and hopes for the future, takeaways before we wrap up?
Well, why don't we start off and maybe kind of go around here. If there was if you had a few take-home points for people, and we'll go start with Aditi, go the same order. What would your take-home points be in terms of things you've learned that might be beneficial to our audience?
So that's a great question, actually. I think if for everybody that's here, I think if it's one thing I want you to remember is that there is treatment, that this is treatable, it is a fight worth winning. And the biggest thing is that you do have to keep advocating for yourself. As Sydney mentioned, how she sat in the waiting room for 2 hours, which is insane, by the way, Sydney. I am so sorry you had to go through that again. But when I experienced my TIA, my left hand went numb and I knew what was happening. And I literally picked up all of my paper results, because I would print them. And I literally went to the emergency room and slammed it in their face and said, I'm having something going on with me right now. I need you to let me in. I am not waiting. And it was in the age of COVID. I was petrified of being in COVID. And I slammed my results and I was like, my cholesterol is 400. Let me in. And that's what got them to really. So sometimes you do have to be a little in their face, but keep going and keep trying and keep talking about it and lean on your loved ones. Like, the biggest thing for me was that my best friend, who's Samantha Loeb, she was with me through the entire process, and you're not alone. Don't ever feel alone when you're dealing with this.
So, that's a great suggestion, that maybe something, and it's hard to always have your records, but maybe a medical information card that you keep in your purse or your wallet, and it has some numbers and facts on there. When people see that and they see that number, that it opens the eyes up, and so I think that's a nice thing. It's a very good idea to get attention quickly with it, and particularly when this comes to if someone's having chest pain, because what we do know is that when it's coming to your basically, so getting in, and that's an important thing for the audience. If you're feel like something that's, shortness of breath, just something feels wrong, you can actually go to some of the ERs that are affiliated with a major hospital, and they will quickly do an EKG, blood test, blood markers for damage, and they'll get the results back within an hour. And it's better to err on the side of caution and then write it off and say, well, it's indigestion, or, I just feel bad today, or something else with that. And you're shaking your head because you've been through this with it. But it's what ends up happening is that early intervention can make a very big difference in terms of heart and muscle with it. So that's a great thing about telling your story and even having documents to back it up. Sydney, do you want to give some?
Yeah, absolutely. And I want to, oh my gosh, I want to be able to address this as both a patient of FH and as a future clinician. Going off of like what everyone has said, unfortunately, the most important thing is for patients with FH to be educated and have a bunch of knowledge about FH so they can advocate for themselves in the doctor's office, because unfortunately you can't always count on your doctor to know all of this stuff about FH. So at least in my experience, although I generally feel very lucky that I've had clinicians that have diagnosed me with FH when I was a teenager and that I've been treated since then, and I haven't had any major cardiac related events, it is still so important to advocate for yourself. But by the same token, as a clinician, regardless of your discipline in medicine, you are always taught to look at the clinical signs. You're taught to use your critical thinking skills and to address the symptoms that you're seeing. And that is something that I often feel like is not addressed with someone like me, who is young, seemingly healthy, and a woman with high cholesterol. I think that clinicians need to do better in being aware of what FH is, because I know it's really common. And my favorite thing to do when I'm in clinical or when I'm around other clinicians is to be like, hey, do you know what familial hypercholesterolemia is? And most of the time they look at me like I have three heads, and they don't know what it is. And I have an opportunity to tell them like, hey, look at me. Do I look unhealthy to you? But what if I told you that my cholesterol was 708? And they're like, that's ridiculous. You should be treated for that. And I was like, yes, yes, exactly. That's what you're supposed to do. But unfortunately, that's not always the case. And I always feel really happy. Like I worked in a cardiothoracic ICU this semester, and I talked to my preceptor about it, and she's in school to be a nurse practitioner. And she said the week after I had talked to her, they learned about FH in lecture. And she was like, oh, I know someone with FH. These are all the clinical signs, and now I can put the pieces together. And I just wish that would happen a little bit sooner, and it wouldn't have to be, you have to see a person who's really young with this high cholesterol and then see them on ECMO in the hospital, or see them once the damage is already done. Being proactive is really important for clinicians. So I know that was a lot, but a
lot of good messages there.
The main takeaway is patients need to be aware of what FH is to be able to advocate for themselves, but clinicians also need to do their part in doing what they're supposed to do for patients, which is educate and treat properly.
Brandon?
First, I want to correct myself. My daughter's LDL is 245, and her total is over 300 as a 2-year-old. So there goes that. And what we were saying about being in the hospital in the ER, I can't tell you the countless times I've been in there, and they check your enzymes, check your EKG, and say, it's not your heart, have a good day. And then I'll be in the cath lab the next day and getting another stent, getting bypass surgery. And so you really have to go for the second opinion, or don't stop at, you're not having a heart attack, see you later, you can go home.
Right.
Just don't settle for that answer, because they are doctors but they're not specializing in FH. They're not always looking out for the underlying issue, just what's happening right there. So I've been sent home so many times, and they say you're fine, you go home, and then the next week I have my 4th heart attack. So it's not fair. You really have to keep going. You have to, don't settle for the first opinion ever. And I almost did that this year after I had my 4th attack back in August, and I was waiting on my doctor to make a decision for me, and I chose to make a decision for myself. And I reached out to the Mayo Clinic, and now I have surgery scheduled on the 29th, getting anywhere from 3 to 5 stents, as well as a stent in my leg and in my carotid. And none of that was going to happen if I settled for the first opinion and the first one to say, here, this is what you need done. See you later. So my biggest message to anybody with FH or suspicion of FH is it's not a death sentence. You can get treated for it. You don't need to halt your entire life and just say, oh my gosh, I have this disease, because you can live a great, healthy, wonderful life with FH. You can go forever. I mean, I told my wife I'm going to outlive her until I'm 99 just to spite her, just to annoy her as long as possible. But the key to FH is early detection. I think every one of us as advocates, parents, patients, we need to reach out to more parents, more pediatricians, pediatric units. They have to know about this. And like you said earlier, for the adopted child, the orphan that doesn't have a family history, they have to be screened. The only way we can beat FH is by early detection and treatment. And it just, as my daughter, seeing her numbers for the first time yesterday after we had genetic testing last year, so I knew she carried my gene, but seeing those numbers, they're really real for me. So I told everybody I was more nervous about crying talking about my daughter than anything. Seeing those numbers and looking at her, I'm her biggest advocate. And now I have to lead by example and show her to never settle for the first opinion, to keep fighting. Heart disease takes a fighter, it takes a warrior to get through it. And everybody on this panel with me right now, you're the strongest women I've ever met. Keep going, keep fighting for everything that you need. Don't settle. This is your health, this is your life. Just fight for everything. Keep going.
Well, thank you, Brandon. Let me bring up one final point that come from my practice. And Sydney mentioned this, is that there's an age in life when she said 18, you got rebellious, I think, or was that? So, I one of the things I regret is having a patient, and I was treating the mother and then the uncle, and then her son. He got tested a little bit late, and we started therapy. He was maybe 17 or 18. Went to college, decided, big pharma is terrible. I'm not going to take a statin. I'm going to do everything naturally. And he was, great diet, exercise, became a competitive ballroom dancer, died at age 29 in a dance event, sudden death. His mother and uncle, fine, in their 60s and 70s. So heterozygous FH, if you start early, and that's someone's talking in here, one reason we want to start early is because when kids are, 9 or 10, they're not rebellious. You can start much earlier in life, but they just take their pill every day. And then you could, if you have to, even choose 2 pills. There's a time in life when they actually think their parents are smart and they listen to them. And then later on, they're like, anything but what my parents tell me to do. So start early. And then also you've gotten the lipids down. with it. It's a very important issue. So that's just a take home. Advocate not only for yourself, but for your children and all the kids in the family, that they get screened and started early. And I'll turn it back over to Kat.
Well, thank you all so much. This has really been incredible. And I really want to thank Dr. Ballantyne for this amazing, directing the traffic on this amazing conversation, and Aditi, Brandon, and Sydney for sharing so much of yourselves and your story. I think you're all great examples of what can be done when you do have the tools that you need. And that is the goal of the Family Heart Foundation. You're all part of our Advocates for Awareness program, gone through the training where you get access to the information that you might need to advocate for yourself and also for others. And that is our hope at the Family Heart Foundation, is to give everybody those tools. I'll say that, so you can learn more, everybody watching can learn more on our website with our webinars. You can find a specialist on our specialist map. We are there for you to help you navigate. We have a care navigation center on our website now where you can ask questions. I'll say that I thought I heard on the topic of this discussion today about barriers, what gets in the way. I heard so much that is unfortunately similar amongst you, the lack of urgency that there seems to be to diagnose severe hypercholesterolemia and FH. And then the lack of urgency to get to those treatment goals, as Dr. Ballantyne highlighted, and what we accept as families. In my family, we have FH also. What's normal? We'd have to shift our thinking to make what we consider normal really unacceptable as early heart disease in ourselves and in our family members. So finding the right doctor and really advocating for yourselves. And we hope you find the tools that you need on our at the Family Heart Foundation to advocate for yourselves. Those delays in diagnosis, and then the delays in initiating treatment, the delays in reaching treatment goals, those were common among you. Resistance to combination treatment, as Dr. Ballantyne highlighted. And then really, most importantly, the devastating consequences of all this delay. Each of you are young and you've had cardiovascular events. That's what we see in the Cascade registry and in all the work that we do, that there are real consequences for the underdiagnosis and undertreatment of FH. So our goal, of course, is to change all that. And we're really grateful to all of you for helping us to do that by participating in this discussion. We invite anybody who's watching to join us, to volunteer as an advocate for awareness. You can visit our website. We have a form to apply for this program. We do training and then help you to get the word out in your community, amongst the medical community, and in the general public. And if you find what we provide helpful, we really hope that you'll show your support with donations to the Family Heart Foundation. And finally, I just really want to say thank you to all of you and to everybody who's watching. Really appreciate it. Thank you, everybody.
Thank you, and thank you to the FH Foundation, the Family Heart Foundation. You've been a turning point in the care in my life and with my journey in FH, and just want to thank all of you that are a part of the foundation. It's really great to have you.
Thank you.